This is Chapter 15 of the Maternal Newborn Therapeutic Procedures to Assist with Labor and Delivery. In this chapter, the various therapeutic procedures to assist with labor and delivery will be discussed. The therapeutic procedures that will be reviewed include external cephalic version, Bishop score, cervical ripening, induction of labor, augmentation of labor, amniotomy, amnioinfusion, vacuum-assisted birth, forceps-assisted birth, episiotomy, cesarean birth, and vaginal birth after cesarean birth. External cephalic version is an ultrasound-guided hands-on procedure to externally manipulate the fetus into a cephalic lie. The procedure is performed at 37 to 38 weeks of gestation in an inpatient setting. There is a high risk of placental abruption, umbilical cord compression, and emergent cesarean birth with this procedure. Contraindications to performing a version include uterine anomalies, previous cesarean birth, cephalopelvic dysportion, placenta previa, multifetal gestation, ogliohydramnios, third trimester bleeding, uteroplacental insufficiency, and nuchal cord. Indications: potential diagnosis, a malpositioned fetus in a breech or transverse position late in gestation. Considerations: preparation of the client. Have the client sign an informed consent form. The provider will perform ultrasound screening prior to the procedure to evaluate fetal position. Locate the umbilical cord, assess placental placement to rule out placenta previa. Perform a non-stress test to evaluate fetal well-being. Ensure that RHO-D immune globulin was administered at 28 weeks of gestation if the mother is Rh negative. Administer IV fluid and tocolytics to relax uterus to permit easier manipulation. Ongoing care. Continuously monitor FHR patterns to assess for bradycardia and variable decelerations during the version and for 1 hour following the procedure. Monitor vital signs. Interventions. Monitor fetal activity, fetal heart rate, and fetal heart rate pattern. Monitor uterine activity, contraction frequency, duration, and intensity. Monitor for a decrease in fetal activity. Bishop score. A Bishop score is used to determine maternal readiness for labor by evaluating whether the cervix is favorable by rating the following: cervical dilation, cervical effacement, cervical consistency like firm, medium, or soft, cervical position, posterior, mid-position, or anterior. The 5 factors are assigned a numerical value of 0 to 3, and the total score is calculated. Indications: any condition in which augmentation or induction of labor is indicated. Client readiness. A Bishop score for a client at 39 weeks of gestation should be a score of 8 or more, which is indicative of a successful induction. Cervical ripening. Cervical ripening by various methods increase cervical readiness for labor through promotion of cervical softening, dilation, and effacement. Cervical ripening can eliminate the need for oxytocin administration to induce labor, lower the dosage of oxytocin needed, and promote a more successful induction. Administration of a low-dose infusion of oxytocin is used for cervical priming. Mechanical and physical methods. A balloon catheter is inserted into the intracervical canal to dilate the cervix. Membrane stripping and an amniotomy can be performed. Chemical agents. Based on prostaglandins, they are used to soften and thin the cervix. They can be in the form of an oral medication or vaginal suppositories or gels. Misoprostol is a prostaglandin E1, and dinoprotasone is a prostaglandin E2. Indications: potential diagnosis. Any condition in which augmentation or induction of labor is indicated. Client presentation: failure of the cervix to dilate and efface, failure of labor to progress. Considerations: nursing actions. Ongoing care includes the nurse assessing for urinary retention, rupture of membranes, uterine tenderness or pain, and contractions and vaginal bleeding. Non-reassuring fetal status interventions. Obtain the client's informed consent form. The client should remain in a side-lying position. Assist with augmentation or induction of labor as prescribed. Notify the provider if uterine tachysystole or non-reassuring fetal status is noted. Proceed with caution in clients who have glaucoma, asthma, and cardiovascular or renal disorders. Complications: tachysystole. Administer subcutaneous injection of terbutaline. Non-reassuring fetal status. Apply O2 via face mask at 10 liters a minute. Position the client on the left side. Increase the rate of IV fluids and notify the provider. Induction of labor. Induction of labor is the deliberate initiation of uterine contractions to stimulate labor before spontaneous onset to bring about the birth by chemical or mechanical means. Methods is mechanical or chemical approaches, administration of IV oxytocin, nipple stimulation to trigger the release of endogenous oxytocin. Indications: any condition in which augmentation or induction of labor is indicated. Elective induction or for non-medical indications must meet the criteria of at least 39 weeks of gestation. Elective inductions that do not meet recommended criteria can result in increased risk for infection, premature delivery, longer labor, and need for cesarean birth. Client presentation: post-term pregnancy, greater than 42 weeks of gestation. Dystocia is prolonged difficult labor due to inadequate uterine contractions. Prolonged rupture of membranes, which predisposes the client and fetus to risk of infection. Intrauterine growth restriction, maternal medical complications, fetal demise, and chorioamnionitis. Considerations: prepare the client for cervical ripening. Obtain the client's informed consent form. If cervical ripening agents are used, baseline data on fetal and maternal well-being should be obtained. Monitor FHR and uterine activity after administration of cervical ripening agents. Prepare the client for mesoprostol administration. Mesoprostol is a tablet inserted vaginally to ripen the cervix. Encourage the client to void prior to the procedure. Prepare the client for oxytocin administration. Prior to the administration of oxytocin, it is essential that the nurse confirm that the fetus is engaged in the birth canal at a minimum of station 0. Initiate oxytocin no sooner than 4 hours after the administration of mesoprostol and 6 to 12 hours after dinoprotasone gel installation or removal of a dinoprotasone insert. Use the infusion port closest to the client for administration. Oxytocin should be connected to the main IV line and administered as an intermittent IV bolus via an infusion pump. An intrauterine pressure catheter, or IUPC, can be used to monitor frequency, duration, and intensity of contractions. When oxytocin is administered, assessments include maternal blood pressure, pulse, and respirations every 30 to 60 minutes and with every change in dose. Monitor the FHR and contraction pattern every 15 minutes in the first stage of labor, every 5 minutes in the second stage, and every change in dose. Ongoing care. Assist with or perform administration of labor induction agents. Increase oxytocin until desired contraction pattern is obtained and then maintain the dose if there is contraction frequency of 2 to 3 minutes, contraction duration of 70 seconds, and contraction intensity of 50. Discontinue oxytocin if uterine tachysystole occurs. Clinical findings of uterine tachysystole include the following: contraction frequency of more than 5 and 10 minutes or a series of single contractions lasting greater than 2 minutes, or contractions of normal duration occurring within 1 minute of each other. Contraction duration longer than 70 seconds. Contraction intensity that results in pressure greater than 50. Uterine resting tone greater than 15 between contractions, and no relaxation of uterus between contractions. Complications: non-reassuring FHR, abnormal baseline less than 110 or greater than 160, loss of variability, late or prolonged decelerations. Notify the provider. Document responses to interventions. If unable to restore reassuring FHR, prepare for an emergency cesarean birth. Augmentation of labor. Augmentation of labor is the stimulation of hypotonic contractions once labor has spontaneously begun, but progress is inadequate. Some providers favor active management of labor to establish effective labor with the aggressive use of oxytocin or rupture of membranes. Risk factors requiring augmentation of labor. Administration procedures, nursing assessments, and interventions and possible procedure complications are the same for labor induction. Amniotomy. An amniotomy is the artificial rupture of the amniotic membrane, AROM, by the provider using a hook, clamp, or other sharp instrument. Labor typically begins within 12 hours after the membrane rupture and can decrease the duration of labor by up to 2 hours. The client is at an increased risk for cord prolapse or infection. Indications. Labor progression is too slow and augmentation or induction of labor is indicated. An amnioinfusion is indicated for cord compression. Considerations. Ongoing care. Ensure that the presenting part of the fetus is engaged prior to an amniotomy to prevent cord prolapse. Monitor FHR prior to and immediately following AROM to assess for cord prolapse as evidenced by variable or late decelerations. Document the time of rupture, obtain temperature every 2 hours, and provide comfort measures. Amnioinfusion. An amnioinfusion of normal saline or lactated ringers is instilled into the amniotic cavity through a transcervical catheter introduced into the uterus to supplement the amount of amniotic fluid. The installation reduces the severity of variable decelerations caused by cord compression. Indications. Ogliohydramnios, which is scant amount or absence of amniotic fluid caused by any of the following: utero-placental insufficiency, premature rupture of membranes, and post-maturity of the fetus. Fetal cord compression secondary to post-maturity of fetus, macrosomic, large body, which places the fetus at risk for variable deceleration from cord compression. Interventions. Assist with the amniotomy if membranes have not already ruptured. Membranes must have ruptured to perform an amnioinfusion. Warm fluid using a blood warmer prior to infusion. Fluid should be room temperature. Perform nursing measures to maintain comfort and dryness because the infused fluid will leak continuously. Monitor the client to prevent uterine overdistension and increased uterine tone, which can initiate, accelerate, or intensify uterine contractions and cause non-reassuring FHR changes. Monitor fluid output from vagina to prevent uterine overdistension. Vacuum-assisted birth. A vacuum-assisted birth involves the use of a cup-like suction device that is attached to the fetal head. Traction is applied during contractions to assist in the descent and birth of the head, after which the vacuum cup is released and removed preceding delivery of the fetal body, following recommendations by the manufacturer for product use to ensure safety. Vertex position, cervical dilation of 10 centimeters, absence of cephalopelvic disproportion, and ruptured membranes. Associated risk is scalp lacerations, subdural hematoma of the neonate, and cephalohematoma. Indications: maternal exhaustion and ineffective pushing efforts, fetal distress during second stage of labor, and generally not used to assist birth before 34 weeks of gestation. Preparation of the client. Provide the client and their partner with support and education regarding this procedure. Assess and record FHR before and during vacuum assistance. Assess for bladder distension and catheterize if necessary. Interventions. Alert postpartum care providers that vacuum assistance was used. Observe the neonate for lacerations, cephalohematomas, or subdural hematomas after delivery. Forceps-assisted birth. A forceps-assisted birth consists of using an instrument with 2 curved spoon-like blades to assist in the delivery of the fetal head. Traction is applied during contractions. Indications: prolonged second stage of labor and need to shorten duration, maternal exhaustion, fetal distress during labor, abnormal presentation or a brief position requiring delivery of the head, arrest of rotation. Considerations: explain the procedure to the client and their partner, assist the client into a lithotomy position, assess to ensure that the client's bladder is empty and catheterize if necessary. Assist with the procedure as necessary. Interventions: Assess and record FHR before, during, and after forceps assistance. Observe the neonate for bruising and abrasions at the site of forceps application after birth. Assess for facial palsy. Complications: lacerations of the cervix, lacerations of the vagina and perineum, injury to the bladder, facial nerve palsy of the neonate, facial bruising of the neonate, subdural hematoma of the neonate. Episiotomy. An episiotomy is an incision made into the perineum to enlarge the vaginal opening to facilitate birth and minimize soft tissue damage. Indications: shorten the second stage of labor, facilitate forceps-assisted or vacuum-assisted delivery, prevent cerebral hemorrhage in a fragile preterm fetus, facilitate birth of a microsomic large infant. Considerations: the site and direction of the incision designates the type of episiotomy. A median or midline episiotomy extends from the vaginal outlet towards the rectum and is the most commonly used. It's effective, easily repaired, generally least painful, and associated with a higher incidence of third and fourth degree lacerations. A mediolateral episiotomy extends from the vaginal outlet posterior lateral, either to the left or right of the midline, and is used when posterior extension is likely. Third degree laceration can occur, blood loss is greater, and the repair is more difficult and painful, and local anesthetic is administered to the perineum prior to the incision. Encourage alternate labor positions to reduce pressure on the perineum and promote perineal stretching to reduce the necessity for an episiotomy. Cesarean birth. A cesarean birth is the delivery of the fetus through the transabdominal incision of the uterus to preserve the life or health of the client and fetus when there is evidence of complications. Incisions are made vertically and horizontally onto the lower segment of the uterus. Horizontal is the optimal incision. Indications: malpresentation, particularly brief presentation, cephalopelvic disproportion, non-reassuring fetal status, placental abnormalities, placenta previa, abruptio placenta, high-risk pregnancy, previous cesarean birth, dystocia, multiple gestations. Pre-procedure: assess and record FHR and vital signs. Position the client in the supine position with a wedge under one hip to prevent compression of the vena cava. Insert an indwelling urinary catheter. Administer preoperative medications. Determine whether the client has had nothing by mouth since midnight. If the client has, notify the anesthesiologist. Explain the procedure to the client and their partner and provide emotional support. Intra-procedure: assist in positioning the client on the operating table. Continue to monitor FHR. Continue to monitor vital signs, IV, and urinary output. Conduct instrument and sponge couch per protocol. Post-procedure: monitor for evidence of infection and excessive bleeding at the incision site. Assess the uterine fundus for firmness or tenderness. Assess the lochia for amount of characteristics. A tender uterus and foul-smelling lochia can indicate endometritis. Assess for productive cough or chills, which could be manifestation of pneumonia. Assess for indications of thrombophlebitis, which includes tenderness, pain, and heat on palpation. Monitor eyes and nose, vital signs. Encourage ambulation to prevent thrombus formation. Assess the client for burning and pain on urination. Complications: aspiration, amniotic fluid, pulmonary embolism, wound infection, wound dehiscence, severe abdominal pain, premature birth of fetus if gestational age is inaccurate, vaginal birth after cesarean, which is a VBAC. A vaginal birth after cesarean is when the client delivers vaginally after have had a previous cesarean birth. Indications: selection criteria for VBAC: no other uterine scars or history of previous rupture, 1 or 2 previous low transverse cesarean births, clinically adequate pelvis, clients who have had a prior cesarean for dysfunctional labor, brief presentation, or abnormal FHR pattern, providers immediately available throughout active labor capable of monitoring labor and performing an emergency cesarean birth if necessary. No current contraindications: large for gestational age, malrepresentation, cephalopelvic disproportion, or previous classical for vertical uterine incision. Pre-procedure, review the medical records for evidence of previous low segment transverse cesarean. Assess and record FHR, assess for evidence of uterine rupture, and post-procedure is nursing interventions for vaginal delivery after cesarean birth are the same as vaginal delivery.